Okay. Yes. Okay, who's running the show? Pra. Should I call you Pra? How you doing?
I'm fine, Dr. John. How have you?
Good, good, good.
So
Yeah, we started a little late, but that's okay. You're on YouTube now, live.
we actually have 10 minutes the
Yeah, yeah,
session. I
we
see
have time.
what you did there.
Yeah, you have to be patient with the internet, as you know, is low, so you have to be patient. That's all. You know how it is, right? Are you gonna
So,
are you going to host or who's going to host?
yeah,
Hello,
I have
Dr.
me and my.
John.
Hey, how you doing? I'm Dr. Bennett.
I'm Hermina, and I'm one of the hosts
Okay,
for
good.
tonight.
Okay, who is the main host? I'm going to introduce somebody, and I hope they run the whole show. Would that be possible, or you're not set up for that? Do you have one host? How do you have it
I,
structured? How do you have it structured, Ross?
shall
I mean, it's
I-
informal.
yeah.
We do what we want, but what do you want to do?
So Homina will be opening the show, and then I'll be introducing the speaker, and then I'll be giving the closing remarks. But
Oh,
Homina will be moderating the session.
yeah. Okay, I'll be in the background and, and do anything. But if your bandwidth goes bad when introducing the speakers, I guess Hermina, I guess you can take over, right? Okay, Hermina, are you there?
Yes, yes.
Yeah, so you can take over, right? If her sound goes bad because her internet connection is not too good, and I don't know what you guys want to do, so I'll just you'll have to introduce the speakers too if her internet goes bad. Okay.
Of course, of course.
You look perplexed.
Dr.
Are you perplexed?
No, I'm not perplexed.
Where are you? Are you in Romania?
Yeah, I'm from Romania.
Oh, okay, good. Welcome. Welcome. Okay, very good.
Dr.
Yeah,
Could
go
you
ahead.
please make
Yeah, yeah,
Hermina, and Gaurav the co-host, and also
yeah,
Dr.
sure.
Pant as
Okay, sure. I'm glad that you're being that way. Now, who do you want me to make host? You and who else?
Gaurav Mainadi, if you can find him, Dr. John.
Gopi Nepal?
No, Dr. John, Gaurav Mainadi, Jaurab.
Okay. Oh, Garab.
Yes, Dr. John.
Okay, let me see here. A lot of people coming late. Yeah, we can always start a few minutes late if Prata, should I call you that? Prata?
No worries, Dr. John. Whatever is fine for you.
Okay, yeah, but I want to be proper. I want to speak to you properly. Is it Prata, Pratana, Pratana, Pratana? Okay, Pratana.
Prarthana.
Yeah, Pratana. One tip: if you turn off your video, you'll save bandwidth. Do you know what I mean? But it's okay now. You're coming through now. But if you get in trouble, you might want to turn off your picture because that eats up bandwidth.
Sure, Dr. John.
And we do that in Africa all the time. Matter of fact, we do it for some speakers when they're speaking. In order to conserve bandwidth when they're presenting, they turn off their picture and they can screen share fine. That doesn't require a lot of bandwidth. That's a little tip. Well, we're getting some people here. Okay, if you notice, you guys are on the front page of Neurosurgical TV. Take a look at it. And here I'm going to do something while we're waiting. Prata, I'm going to put some information in the chat and ask people to share it. I'll put the panelists to work. I tell you, this platform is going to change the conference world.
Sure, Dr. John.
Okay, and we're going to explore it right now by seeing if we can use tech. Because you know what, Prata? Tech's going to serve us. We're not going to serve tech, right? Make that tech work for you. Don't make that tech work you. You work it. Okay, and I'm going to try to do that right now. I'm going to put a message in the chat that I want you guys to help me. I'm essentially going to put that information on your Facebook, okay? Because that'll spread the word of what we're doing now. Okay, take that, copy and paste it into your Facebook page and say you're going to start this conference. and you're the panelists in there. How's that, Prof? Are you impressed? Well, Herminia, I know Herminia is impressed.
I am impressed.
Okay, that's good.
The most impressed, I mean.
No, we gotta use these little tools, man, because you know that all you panelists have followers, obviously. So hey, why not tell your followers what you're doing? You're on the panel, in this wonderful webcast. Okay, let me know when you
Dr.
see
John?
let me know when you guys want to start, whenever.
Dr. John,
Yeah.
so we need to share screen at the middle of the session. So is it allowed for the participants to share?
Of course. Yeah, yeah. So the panelists can share. I mean, this is an interactive experience. And we have, no, really. We have neurosurgeons all the time that present, and then one of the panelists will say, "Oh, I got a CT." You know what I mean? Is that what you're asking? Yeah, sure. People are welcome.
The speaker wants to share the video. So one member from our club will be doing so for the speaker. So I just wanted to notify that there's going to be a screen sharing at the middle of the session.
Yeah, you want to test it now?
Yeah, if it's possible.
Or you want to wait? Oh my God, we're
Uh,
getting a lot of people. Hold on, I gotta buzz these people in. Yeah, what I should do is I should make you a co-host, and you can help me actually get these people in, okay? Because I'm in residency now. My residency is using this platform. Okay, so I'm gonna make. Let's see. I'm gonna make you co-host. Okay, Pratha. Not
yes,
you?
Dr. John.
Okay, and you let the people in. Okay, and you're gonna let the people in. That will help me. And the other person I have to make a co-host is who?
Hermina.
Hermina, make you co-host. Okay. I guess you're familiar with this platform, Hermina?
Can you repeat, please?
You're familiar with the platform?
Yes.
Oh, good. Okay, I gotta you want to be co-host, right? How are you listed? I'm not getting you here, Herminia.
Hermina Dicu. Hermena.
Oh, okay, I don't see it there. Do you see it there? I don't see. I'm sure you are because you're in here. You have another name? You see the name list on the right. Do you see that name list or no?
DI.
Oh, DI. Okay. I was spelling it wrong. I said H. DI.
CU.
Oh, DU. Okay, I can't find it. Well, it's not important. Are you ready to start? It's Herminia, I thought, right? HERM.
ENA.
Oh, your name is Ina.
No, I will.
Okay, so
I
what
will
is your
write
first
it in the
name? What
chat.
is your first name?
You can call me Andrea.
Andrea. Okay. Well, what's your full name? I've got to introduce you.
I will put it in the chat.
Okay. And you're a med student in Romania?
Yes.
Oh, there we go. Okay, are you ready to start, Pratha? Hello? Hello?
We are waiting for the speaker. We are waiting for the speaker, Dr. John.
Oh, okay. No problem. Man, we got all these people to buzz in. Are you admitting them, Pratha? Did you learn how to do that? Okay, I'm going to do it here.
Yes.
Yeah, the speaker's probably trying to get in. There's 40 people in the waiting room. But I should make them wait, right, Termina?
Yes.
So I am on phone, you know. I am using my wife's computer, so it's busy upon. but this is me. So
Okay,
I have my video.
okay. Hi, I'm
Hello,
Dr.
Dr.
I'm Dr. Bennett. Nice to meet you. And Hermina is moderating. Have you meet Hermina?
Good evening, doctor.
Oh, okay.
Yeah, good evening. Nice to see you all.
You're in Kathmandu also?
Yes, I'm in Kathmandu, yeah.
Okay.
Where are you
No.
from?
I'm in Miami.
Miami. Oh,
Yeah, I was in Kathmandu. I ran a webcast from a cyber cafe in the nice part of town there. Thames, what's it called?
Thames, yeah.
Yeah, that was great. The internet was strong in this internet cafe, which I was surprised.
So I have sent my video presentation to the, to them,
Yes,
so they
okay.
can just share the screen, and then I'll be available for any questions.
Yeah, sure. This is pretty informal. You know, we'll just work it out. And who has your video?
I have.
Okay, do you want to test it before we start? Let's test it. Okay, like you're going to
Okay,
show
thank
it.
you.
Okay, we'll test it out. Okay, make sure this. Okay, try it again. You got to make sure the sound works. Okay, okay. I want you to play it again and start the sound.
Hello, everybody. This video is mainly.
Okay, excellent. Okay, excellent. You got it.
Last year medical student.
Okay, Prath, you ready to start?
Yeah.
Okay, here, Prath, are you ready?
Yeah, I'm ready. Yeah.
Okay, now I'm talking to Hermina. Hermina, are you ready?
Yes, yes.
Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from sunny Miami Beach. It's Dr. John Bennett broadcasting for Neurosurgical TV. We have the pleasure of having a Walter Dandy meeting, combination of the Walter Dandy chapters of Nepal and Romania. And I suspect the germ was planted when you guys had some kind of conference last year. I imagine that's how the collaboration ensued. But anyways, let me introduce you to Hermina, a medical student from Romania, and she's going to moderate. Welcome, Hermina.
Nice to see you guys. Good afternoon or good evening, everyone. Good to see you all here, and thank you for joining us tonight. We are glad to officially announce this tremendous joint event in collaboration with Dandy Neuro Club from an amazing and interesting country, Nepal. My name is Hermina, and I'm fifth-year medical student in Bucharest, and I'm the head of PR department of Walter E. Dandy Neurosurgical Club Romania. I want to introduce a part of my team from Walter Dandy Romania, that is present here with us, Max.
Hello, good evening.
Dragos.
Hello, my name is Dragos. I'm an ambassador from Romania and I'm a member of the Dandy Club in my country.
And Madeline.
Hello, good evening. I'm a member of the scientific department here in Romania.
Moreover, as a housekeeping rule, if you have questions during the meeting, you can put them in the chat and ask them at the end of the session when it will be the Q&A session. In this regard, for the Q&A session, either we will read the question for you, either you can read them by yourself. This being said, I give the floor to my colleague from Nepal, and let's enjoy this marvelous lecture, and also greetings from Romania.
So hello everyone. Thank you so much, Harmina. I'm Pratna, currently a fourth-year medical student here in Nepal and working as the president of Walter E. Dandy Neuro Club in Nepal. And it is a huge honor for us because today we have Dr. Basanta Pant with us. I also would like to introduce the counterpart of our club who are present here. So Gaurav, if you could introduce yourself.
Hello everyone, I am Gaurav Minali, currently a fourth year medical student at Nepal's Army Institute of Health Sciences. Thank you.
Pinky.
Hello everyone, I am Pinky Jha, currently a fourth year medical student from Nepal's Army Institute of Health Sciences. We're glad to have you all here.
Mahendra.
Hello everyone, my name is Mahendra. I'm a final year medical student at National Medical College. I'm a public relations officer at Dandy Club Nepal. I'm glad to be here. Thank you.
We also have a few of our officers joining in, but I'd like the speakers without delay. Dr. Pant, it is an honor to have you here today because I think every Nepalese person has heard anecdotes about him, and he has been a huge inspiration for all medical students here in Nepal. And talking about Dr. Pant, he's currently working as the Chief Neurosurgeon in Annapurna Neurological Institute and Allied Sciences here in Kathmandu, Nepal. And he has his special interest in epilepsy surgery, in motor disorder surgery, as well as psychosurgery about deep brain stimulation and lesioning of the brain. And he has been working to raise the line for Nepal. We cannot explain the inspiration he has been for Nepalese neurosurgery. And it is such an honor to have you here, sir. We would like to hear a few words from you before we begin the session. Dr. Pant, you're muted.
You have to unmute yourself, sir. There you go.
Yeah. It's a big surprise for me that the medical students on Saturday evening, rather than boozing out, they are here to listen to my lecture. It's a big surprise to me. So I hope I have done justice to the young peoples, and I look forward to any questions that arise at the end of the session. Thank you. Thank you for having me here.
Yeah, we have more than 100 people in the panel, Doc.
Yeah.
Okay, go ahead, Hermina. Where are we going from here?
I think we can start with the session.
I think we should proceed.
Okay, very good.
Hello, everybody. This video is mainly dedicated for last year medical students, interns, house officers, and maybe it will also be useful for residents who want to understand brain tumor, and that also mainly of high-grade glioma. I'm Basant Pant from Annapurna Neurological Institute. So if you look at the incidence of tumor, then the breast cancer, lung cancer, large bowel, prostate, these are the highest killer of tumor. But if you look at the brain and CNS tumor, it occupies about 2% of the whole tumor that the human being can suffer from. And if you look at the incidence, it's about 23 per 100,000, and the prevalence is about 48 per 100,000. And 1/3 of that is high grade, 2/3 of that is low grade. So low grade is more commoner than high grade tumor. And if you look at this age distribution, then you can see that there is a small peak here in the younger age group. But as they progress, it decreases, and then again it rises somewhere around, the peak is somewhere around 60s or 50s, 60s. So most of the tumor in the world that occurs somewhere around 50 to 60s. So that is also a period where you can have any kind of tumors, and that is also so with brain tumors. And slightly male is more affected with glioma than females. So I just want to show you this picture where this gentleman was, had a very, very big brain tumor which invaded his skull, which eroded his skin, and he was actually using this as a pillow, and he was sleeping on the tumor itself. Till it started eroding and smelling and his wife left him, then only he came to us for treatment. So if people can die of tumor, they can also live with it. And so, just to give you an example how extensive but benign a tumor can be, this is obviously a benign tumor. And then we did a very, very extensive removal of this tumor. And then our main goal was to remove the tumor, but also to bring his wife back. But then, unfortunately, his wife never came back. But then we could remove his tumor. Probably he found another wife or so. Anyway. And another example of how extensively our tumor can be, this young gentleman, this is a post-op scan where you can see that, whole of his back is full of tumor. And this is a neurinoma, it's not a glioma, just to give you an example of how extensive a tumor can be. The doctor is, holding the whole of the tumor that we have removed. So most of the time we remove small chunks of tumor from the body, but sometimes it can be so aggressive and we have to remove such a large amount of tumor. So now coming back to my main theme of presentation today. So brain tumor are diverse group of neoplasm arising from different cells within the CNS. A systemic cancer or it can be metastasized from other part of the body and goes to the brain. And it can be benign or malignant as with other tumors. And if the origin of the tumor is glial tissue, then we call it glioma. It can be from any other tissue that is present in the brain. But when it comes to origin of the glial tissue, not the neurons, then it's called a glial tumor. And it is divided into two types, a low grade and a high grade. A low grade is a well differentiated, which is not anaplastic, and a high grade is undifferentiated and a very anaplastic malignant cells. And out of these, the glioblastoma multiformis, which is the main topic of the talk today, is the most aggressive form of the tumor out of all these tumors. So when we classify brain tumor glioma into grade 1, grade 2, grade 3, grade 4, then glioblastoma multiformis comes into grade 4 tumor. So if you look at this picture, then you can see that glioblastoma multiformis, multiple forms. It has got a multiple forms, so it's called multiformis. So there is an astrocytic differentiation. You know that it is coming from, the glial tissue. Neuronal nuclear atypia is there. Mitosis can be seen. There is a necrosis because it's rapidly developing, so the vasculature cannot cope with its growth. And there is a microvascular proliferation, as you can see here, and pseudopalisading and necrosis. These are, the hallmarks of glioblastoma multiformis. And there's a lot of confusion about brain tumor, and if there's a lot of confusion, then they try to make a lot of classification. So there has been a lot of classification that has been made on glioma till date. The first edition which came in 1979, then in 1993 as a blue book, and then the third edition, fourth edition, and then the fourth edition revised, which is the latest, which came in 2016. And these differences is mainly made by histology and lastly by immunohistochemistry and also genetic study. Once we started doing genetic study, then we started understanding that although histologically all look same, but then genetically they are totally different, and their prognosis, their long-term survival rate was also totally different. So that's why the latest revision of 2016 came up. So as I have just said, molecular and immunohistochemical testings, which includes mainly that change the scenario of glioblastoma multiformis, is IDH1, mainly IDH1 mutation, whether there's a mutation or not, and also IDH2 mutation, If you have an IDS1 mutation, which means that they have got a good prognosis and good biomarkers, and this can be done by immunohistochemistry. And if there is a, IDS1 is a wild type, there is no mutation, then it has got a poor prognosis. And also there is a 1p19q codeletion, which is mainly seen in oligodendroglioma. So if astrocytoma is mixed up with the oligodendroglioma, then you can see this codeletion. And if you see this codeletion, then that tumor has got a good prognosis, although it's a glioblastoma multiformis. And this can be done by these PCR and FISH techniques. And also another biomarkers is important biomarker. There are many biomarkers, but I've just quoted the most common ones, the ATRX gene mutations, and seen in 45% of anaplastic astrocytoma. And if you see this, then it's a hallmark of this is an astrocytoma and nothing else. And if you see this, then again, there is a good prognosis on these tumors. So what causes brain tumor? Why people have brain tumor? Many patient comes to me and ask me, Doctor, what did I do wrong in my life that I have this? And so it's basically till now, we don't know the cause. So we have to say there is a multiple factors, maybe the genetic factors and maybe the progenetic factors, both environmental factors, both are involved. But some of the genetic factors which is well known are neurofibromatosis type 1, type 2, and Charcot syndrome and some other things. But one of the most identified and cause is ionizing radiation, which is a well-established risk factor. But how much ionizing radiation naturally we are getting, besides atomic bomb or nuclear explosions or accidents, we don't know. So this is an environmental factor. Probably we have very little control till date. And some inclusive like head injury, some food, occupational exposures, electromagnetic field like cellular telephone, like there was a very big, when cellular telephone came, there was a big debate whether cellular telephone is safe for human being or not, because most of the time if you are right-handed, you are carrying the telephone on your right hand. And so you may be prone to right temporal lobe glioma. There was a lot of studies, and some studies said yes, after telephone use, you have more right temporal glioma has increased. But then there was another group of people said no, there's not much of difference. But then still it can be a cause. So most of the time, if you can avoid putting the telephone on your ear itself and use an earphone, then that would be better. And some allergic immune phenomena like has got actually a protective role, like IgE, asthma, eczema. These are the people which seems to have, with the control, which seems to have a little bit low incidence of glioma. So clinical features, they can present with any forms. It doesn't mean that they have got a set form of presentation. As you know, that brain is the only structure in the body which has got selective task performance by selective part of the body. Like frontal lobe has its own work, temporal lobe has its own job, amygdala has its own job, hypothalamus has. So depending on where the tumor is arising, the symptom may vary from hearing loss to vision loss to increase in appetite, decrease in appetite, and so on and so forth. And many times when patients come to us and say, I have a headache, just simply headache, or we just screen the patient for a usual test and then incidental tumor. We have seen many patients who has labeled as migraine for a long time, and then we do a scan and then find that there's a brain tumor. So incidental is not uncommon. So if you go and do a brain scan, then you may have a small tumor that you detect. So recently our proposal is that anybody, any adults who is at the age of 50, they should have at least one scan of their brain, whether it's a CT scan or MRI in their lifetime. So, but then the presentation can be that of increased intracranial pressure like headache, vomiting, some kind of neurological deficit depending on where it is, confusion, memory loss, personality changes if it's mainly on the frontal lobe. About the seizure, there are many books which say that the first seizure should be, you don't treat first seizure or you don't investigate first seizure. But my personal strong teaching is that you must study the first seizure, because every seizure is first seizure in their life. So you may miss that chance of detecting a brain tumor or some, nasty brain pathology. So every seizure should be evaluated, and if everything comes normal, then first seizure you can just ignore and may not treat it. But then that may be the time when you can get some very important information. And but the seizure activity do not correlate with the tumor grade. A tumor in the eloquent area, like speech area, memory area, they will have a very profound deficit, profound neurological symptoms. If it's on the pituitary, you have pituitary symptoms. If it's in the visual cortex, you have visual symptoms, so on and so forth. So for investigations, maybe to start with, we do a CT scan. Most of the time, this is the cheapest and most easily available. The only drawbacks is that it has got radiation effect. So, tend to avoid in children unless it's really necessary. So if you are screening a people just for headache, then probably MRI would be a better solution than CT scan. And the main thing that is said, but then the most important thing is, unless you do an enhanced CT scan, like in this case, the lower picture where you can see a fuzzy, looking, but then you don't know what's going on. But unless you enhance that picture, you don't know whether it is actually some pathology or not. So just plain CT is not enough. So if you want to do, you have to do an enhanced CT scan. And it will have, if it's a glioblastoma, high-grade glioma, then it will have a mixed density. Somewhere it's a necrosis, somewhere it's a cellular proliferation, so the density will be mixed. If there's a calcification, then most of the time it says that it is a low-growing, low tumor. So there can be a cystic component on the necrotic part. There may be some hemorrhage if, the vascular proliferation cannot co-op with the tumor growth, and so on and so forth. And so most of the time the margins are irregular, and there will be hypodense central, and there will be a mass effect because there's some new tissue that has gone, so you can see that it is shifting, and you can see that it has grown and caused a mass effect. So next investigation is that of MRI, which is the standard test where you will do a T1, T2 and FLAIR at least, and an enhanced gadolinium enhanced MRI, where again, unless you do a gadolinium enhanced MRI, you don't see how clearly the tumor is being enhanced, and you don't, you cannot delineate how much to remove, so on and so forth. So if it's a high-grade glioma, then you can again see an irregular margin, maybe central necrosis, area of enhancement, area of non-enhancement. So heterogeneous type of presentation is there. And MR spectroscopy is another test which is routinely done these days, and spectroscopy is actually the test which started MRI itself. So MR imaging started from MR spectroscopy. The chemistry used to use it. So here we study the chemistry of the brain and the brain tissue, And most of the time, if it's an elevated choline like this, very high choline and decreased acetyl aspartate in AA, then it suggests that it is a high-grade glioma. So you can put your voxel in different parts of the brain and see how much of choline and N-acetyl aspartate and creatinine and so on and so forth. So different chemical structures will give you whether it's a low-grade glioma or a high-grade glioma, you know. So this is a very good information, especially when you are confused with a tumor and infection. Most of the time, this will give you a very good picture of what you are dealing with. And another test is to look at the blood flow of the brain itself, which is called dynamic susceptibility contrast MRI, where you can look at how much the blood perfusion is happening inside that tumor. And most of the time, it is a high-grade glioma. There's a lot of metabolism going on. So there's a lot of blood flow in that area, and then you can pick that up by a graphic, and there is a ratio that you can have, cerebral blood volume ratio, and that will give you, automated calculated values, which can give you a hint about whether it's a glioma, low grade or high grade. Like these two are high grade and low grade gliomas, which has got a different values here. And to add on, like this is one of our patients where you can see there's a glioma right sitting on the motor cortex. And now we want to know which part of our body correspond to that, and whether we removing that part of the tumor, we are going to damage any structure or not. So when you do a finger tapping test with an MRI, which is called functional MRI, fMRI, hand tapping. So this is a hand area where you can see that the activation is more. It's again looking at the blood flow in that area. If you tap your hand, then that area of the brain will have more metabolism. So you can see it like this. And this is the leg area. So these are the parts which we have to avoid in order to remove this tumor so that we don't give deficit to the patient. So this is very, very important add-on test that we can do on a tumor patient. Another test that we routinely do these days is called diffuse tensor imaging, DTI, which gives you a tactographic, flow of the fibers that connects from the brain to the spinal cord and to the periphery. So different tracts will have different colors, right and left like green, anterior corticospinal tract will have blue, and front to back will have red, and different colors can be designed, designated to different tracts depending on whether it's a right and left, whether it is front to back, or whether it's up to down or down to up, something like that. And like in this case, the previous case, same case, where you can see that these are the part that you want to avoid so that you don't give any motor deficit. The blue one is a corticospinal tract. Now, SPECT and PET are two very important tests that you can add on to give you some examples of how much, the metabolism that is happening in that part. And sometimes to detect smaller tumors also it is helpful, and it will also give you some conclusion, some idea about how aggressive the tumor is. But PET scan is not mandatory before doing any brain tumor surgery. So it's an add-on information that you can get. Now, before you go on to operate on somebody, then you need to know the language area and the memory area when it comes to temporal lobectomy. So most of the time we have left side is the dominant side, but sometimes, we can have a right-sided dominance also, like in this lady. So we inject a propofol or barbiturate, whatever you have, and then you inject it directly into the carotid artery and knock down one part of the brain. So they become paralyzed. So see, we injected on left side, she became paralyzed on right side. And then she will stop speaking if it's left side of the brain is controlling her, speech. And then we also ask for memory test. We show her some cards and then ask her what was the card that we showed her before we injected the propofol. So if she can properly answer, there are some scores. Then if she can answer, then we know that the memory, even if you remove that part of the hippocampus, amygdala, then the patient will not have any problems. So this is called water test. So sometime for language and memory, we do this water test as well. And so now when it comes to a lesion where there's an extensive involvement of the insula, the temporal lobe, the frontal lobe, and the tumor has gone into the basal ganglion and into the internal capsule, then you need to have some kind of study during surgery so that you know that you are not damaging the brain when you are operating on them. So in such cases, we use different techniques, and most of the time we use motor evoked potential like this, which is implanted on the skull itself, and then there are some signals that we pass, electrical signals that we pass through the skull, and then we record it in the hand to see whether we are damaging the corticospinal tract or not. Or we can also test the other pathway, which is a somatosensory pathway, and see that we are not damaging the sensory pathways. So this can be done. Neuronavigation, I will talk again. And cross cytology is something that you can do. If you have a frozen section in your center, that's the best. But if you don't have frozen section, you can at least do a cross cytology. Ask your pathologist to give the result when you are operating, just to give you an example whether it's a high grade or a low grade, so that you can tailor your surgery in time. Awake craniotomy, which I talk again, is something that you can add on. And safe gross total excision is something that we all are practicing these days. So we don't want to give additional deficit to the patient. So our removal will need to be within the safe margin, but then we want to remove as much as possible. Why we need to do that, I will tell you again. So this is a setup of a neuronavigation where the patient can be navigated. Their MRI is recorded in the computer, and their different parts of the body are registered in the computer so that it matches with the MRI. So and then CT scan, MRI can be fused. It's a fusion image. And then when you move your tools, surgical tools, then you can see where you are touching, and then you can actually navigate within the brain and then try not to damage the normal part of the brain itself. So this we routinely use in our setup. And if it's a deep-seated tumor, if it's a difficult deep-seated tumor where navigation will not be correct enough, like in this case, which is pretty deep one, you don't want to miss it, then you can do a stereotactic targeting or do a biopsy, or you can just follow that tractography tract and then remove. So this is a stereotactic frame where you target, this, we wanted to remove the whole of the tumor. So we just, did a stereotactic localization, and then after we localize, then we followed that pathway and remove the tumor. Or you can just do a small borehole and take out the tumor and do the biopsy. Other adjuvant things that you can do is some dye called 5-ALA fluorescent, which you can inject, or other dyes. And then once you are operating, if you have a 5-ALA filter in your microscope, then you can see that there is a blood-brain barrier disruption, and then that 5-ALA brights up, and then it looks red. So the tumor root looks red, and then you can remove that red parts, and then you know that you have done a complete resection. The result with use of 5-ALA and without 5-ALA is controversial, and 5-ALA is very, very expensive. One injection costs about $1,500, but actually 5-ALA is nothing but a fertilizer, and it is find in Alibaba in kg, You can buy it in kgs. That's exactly the same chemical structure. But then, medical people, when they make it a medical drug, then they charge so much that most of the institute will have hesitation using it because of its cost factor. And using it doesn't mean that you are going to cure the patient. It looks fancy, but the result is not that. And again, the awake craniotomy that I will talk just now, like in this patient, there is a diffuse type of glioma in the left side of the brain in a young lady. So you can, which involves the Broca's areas, involves the Wernicke's area. So if you damage this, then they will have a profound, problem. So what you can do in such cases is that our concern is preservation of the speech. So here what we do is it's called sleep-awake sleep technique, where you put the patient into sleep first, and then once you do a craniotomy, which makes a lot of sound, and then once you have reached the desired spot, then you wake the patient up, and then you stimulate the part of the brain that you think is an eloquent area. Like in this lady, we are concerned about the speech, so we are asking her to read the newspaper and then stimulate that part. If we touch the Broca's area, she will immediately stop speaking, and then we know that we have damaged. This is the part that we need to avoid and we should not remove. So to preserve the speech, we can do this, or you can do the same thing on motor area. When you stimulate, then they will have problem on hand movement or leg movement. So you can do that. So with such techniques, you can remove a lot of tumor like this, and 6 months follow-up. She has got no deficit on speech and on memory, and a gross total excision of the tumor can be achieved. For treatment of low-grade glioma, complete surgical resection is curative most of the time. Low-grade means grade 1 and grade 2. WHO grade 1 and grade 2. So, and if you do a near total excision, there is a chance of, delayed secondary malignant transformation is also avoided. And if there's a resection of the optic pathway or a hypothalamus, deep midline structures, maybe you can do a selective resection depending on where it is. And so here is a gentleman where I operated on this child when he was 6 months old, and last time he came to meet me when he was 22 years. So, almost 22 years of follow-up, normal life. They have no deficit. So, brain tumor doesn't mean that your life is gone. If it's a low-grade glioma, then you will have, and you do a good job, then you can have absolutely a normal life. So there are many, many patients like this. But when it comes to a low-grade but diffuse glioma, like the previous one, where the margins are not very clear, then total resection may not be possible most of the time. So you may leave behind some of the tumors. And so you have to give some kind of adjuvant therapy, add-on therapy, like radiotherapy and chemotherapy, which I will discuss in detail. So if it's a diffuse glioma, even if it's a low-grade glioma, most of the time it's not curable, and you have to, give further treatment and further follow-up. Sometimes you come across with this is a low-grade glioma, which is very, very extensive and in the center of the brain, and which involves both sides of the brain. So in such cases, sometimes a very good, thinking, and then with the use of microscope and endoscope, like when I did this surgery many years ago, I didn't have a neuroendoscope, so I borrowed a cystoscope from the uretary colleagues and a laryngoscope from ENT colleagues, flexible scope. and then, made just 2 burr holes, and with microscope and endoscope from one side, and then alternate, we could remove, and then with some improvisation of the technique by ourselves, like nasopharyngeal tube and endoscope is put like that, we could suck out a whole of the tumor from just 2 burr holes. So most of the time, your target is to do a minimally invasive surgery so that you damage the brain as little as possible. Like this much of the brain can be removed from 2 burr holes only, if you can plan accordingly. But most of the time, this is not possible. Like in this case, like this young child has got, extensive tumor on the skull base, into the brain, into the hypothalamus, into the ventricles, into the temporal lobe, and to the ethmoid sinus, and into the sphenoid sinus. So in such cases, you have to do an extensive resection, including the nose, into the eyeballs, and then remove whole of the tumor. So the purpose of showing these 2 things are, depending on the case, you may open small, or if you need, you may have to open extensively and remove as much tumor as possible. This is the boy, this is the pre-op, that is the post-op, and a little bit of scarring is there, but he's a happy boy. And sometimes we face with a problem like this. This is not a meningioma. This is not a glioma. This is a meningioma on a 18 years girl who is 6 months pregnant, and has got an enormously large tumor, and there's a lot of mass effect on her, and pregnancy, the hormones in pregnancy result in rapid growth of the tumor itself. So somehow you have to take it out, but then she was 6 months pregnant. So we made a special table for her, and then so that she is not kept in a prone position, her tummy was not pressed, and then we approached her from the back, and then this is the lady afterward, and with cesarean section she could have a normal child. So these are some of the challenges that you may have to face doing brain tumor surgery at times. So these are some of the bad candidates of glioma that may present to you. Very large left-sided dominant hemisphere, nasty looking, most likely blastoma. And this is a basal ganglia, right-sided, but very deep, again, a glioma. This is called a butterfly lesion, which is through the corpus callosum. It has gone into both sides, so the both of the hemisphere is involved. Or the brainstem is very, very badly involved. Or this is called multicentric glioma, where you can see satellite lesions away from the main tumor. So these are nasty tumors that you may face, and the result most of the time is very, very bad in these cases. So this is another case of a glioma where there is a diffuse brainstem glioma, where you can see that there is nowhere where you can enter into the brainstem. Whole of the brainstem is diffusely involved. And I refused to operate on this child, and I said that radiotherapy would be the only options that he has. But somehow they landed up in another centers where they operated on her multiple times, and they spent a lot of money. And eventually the child died, and the parents became very, very poor. So, we have to be very honest with our patients, and if a case like this comes, there's a limit to what the science can do in a case like this, and we have to be a little bit blunt to them in the first instant, and then tell them that this is incurable, and this we should learn to say that. These are some of the high-grade deep-seated tumors that we actually operated, although these are not very good cases, but then with the help of neuronavigation, stereotaxy, these patients can also be operated. Some of the examples that I have given here. And this is a gentleman which has got a glioma in the brainstem, which has exophytated. There's a mouth that has opened into the fourth ventricle here. So these are the cases that you can actually enter through the tumor and take it out, like in this case. This is the gentleman post-op, so there's no deficit. And you can remove the tumor even if it's in the brainstem. Even if it's like another case where it's a 10 years girl with left-sided weakness of 2/5. First there's a lesion here which is very, very deep into the thalamus. And we did a stereotactic biopsy first on this girl and found that this is a pilocytic astrocytoma. And we thought, oh, we must try to remove this tumor. So, because the pilocytic astrocytoma has got a very, very good long-term survival rate. So, through the tract, we went into the tumor, and then we could go and remove whole of the tumor in this girl. And then, 6 months follow-up scan, which shows that the whole of the tumor has been removed. This is the track that we followed. And she has got a little bit of hemiparesis because we have crossed the internal capsule to reach the other end of the tumor. But then, she is a happy girl. So, and then this girl, eventually her hemiparesis will come up because she's pretty young, and then she will have a normal life. So even if it's a deep-seated tumor, if you think it's a low-grade glioma, then you should attempt to remove it. And so treatment options of high-grade glioma, I would say that there are actually 3 options. One, if you think this is really a very, very high-grade glioma and you are sure by spectroscopy and other tests that it's a high grade, then you should give an option of do no treatment. I will explain to you why I am saying this, because many a times you are just adding few months by doing different surgeries and different other techniques. So you must give them an option depending on where you are, and most of the time in our country, the patients are paying out of their pocket, and you should not, make them poor, and then eventually they will die. Another option would be just to take a biopsy by stereotaxy or neuronavigation and to give them a histological confirmation that you are dealing with a high-grade glioma. Or the third is excision and do a biopsy, and depending on the immunohistochemistry, the histology, whether to add on radiotherapy or chemotherapy. This is how we give all these options to the patients before we go on. The Stroop protocols, which means that a maximum safe resections, which is a kind of a cytoreductive surgery, and the median survival will be about 6 months in glioblastoma multiformis. If you add radiotherapy on that, then you may add another 6 months. So the median survival will be 12 months. And if you add chemotherapy, temozolomide is the drug that you usually use, then again another 2 or 3 months that you are adding, So this is published in New England Journal of Medicine. Most of the time, most of the institute are following this protocol. But then I still say that, do no treatment could be one of the options, and you must tell the patient that this can also be an option for you. But having said that, glioblastoma multiformis recently have changed its picture because glioblastoma multiformis is a devil. But the devil have got a bigger devil and a smaller devil. The bigger devil is a primary glioblastoma multiformis. Primary glioblastoma multiformis means it's a de novo production of the tumor. It just became tumor from without anything, and 90% of the time that is what you are seeing, and it's seen in older age group. There is a genetic alternation, and EGFR is overexpressed. There's a PTN mutation, and IDS1 is a wild type, not a mutant type. So this is a bad case. So if you do a biopsy and get this, then you must tell that out of glioma also, devil, this is a bad devil. And there's another smaller devil which is called a secondary GBM. where there was a benign tumor for a long, long time, and then it transformed into glioblastoma multiformis, which was a low grade, and then they tend to present a little bit earlier in life, and genetic alternation includes IDS1 mutant type and other mutation like I previously said 19q loss and TP53 mutations and so on and so forth. So you have to do a genetic study and an immunohistochemistry and define what exactly is the tumor now, whether it's a bad type or a good type. And then again, after surgery, if it's a really bad type of tumor, then you can tell them that whatever you have done, you have done. Now, probably you don't need to go further for treatment, or there are these options whether you can go for that, but probably that will add another 6 months of life. That's all. So another test that we have not been able to do, but which is a very, very good test, is how much methylation there is, how much of methylation expression there is. And if you can do that test, and more methylation means more, it's a better prognosis. And if you look at unmethylated and methylated, then there's almost like 6 months add on to their life, if it's a methylated. So this is something that we can now add to our patient's study and see whether it's a methylated or unmethylated tumor. So again, coming back to, if you do just biopsy, then probably the patient will die almost by 9 months. If you do an extensive resection, maybe they will survive for 1 or 1.5 year. And with radiotherapy, with chemotherapy, you add on few months in their life. So there is a paper in JNS on 1990 where they took a tumor specimen 2 centimeters away from the margin of enhanced CT scan, and they inoculated that part, the normal brain, which is 2 centimeters away from the tumor, and inoculated that into a nude mouse, which is an immunosuppressed mouse, and also they also grew it, and then look at the motility of the glial tissue. Glial tissue have a motility, and if it's a tumor, it moves more. So in both instances, they saw that the nude mouse grew tumor, and the motility was also high. So they concluded that you have to remove at least 2 centimeters more if you want to do a gross total resection. And then another study was done that was 4 centimeters away from the area, and then this was on 1997, and then again they saw the similar finding. So the conclusion of glioblastoma multiformis is that it is the disease of the whole brain. It is not only a localized enhanced area in the MRI or high intensity area in the FLAIR, but much more larger than that. So most of the time, the most limiting factor is this, that glioma is the disease of the whole part of the brain. And sometimes you have a tumor in this side, the opposite brain also have the tumor, like you saw in the butterfly lesions. So glioma survival, so it only depends on what is the grade of the tumor. If it's a grade 2 tumors, their survival is pretty good. Grade 1 has got absolutely, they become cured. But then as you go on to the grade, then your survival rate becomes less. And if you just do a radiotherapy, the mean survival rate is about 18 months. But if you add temozolomide, probably you add few more months. So this is the malignant brain tumors, overall malignant brain tumors of different diseases like oligodendroglioma, ependymoma, and blah, 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 different tumors. And some tumors has become very good in survival, like anaplastic astrocytoma, it is getting better. But if you look at glioblastoma, the survival rate of glioblastoma has not changed much over the many, many years. So this is another paper which said that the operative skill and operative technique of the doctor has improved so much that the mortality and morbidity immediately after surgery has improved dramatically. And for low-grade glioma, the result has become very, very good. But when it comes to a high-grade glioma, then the perioperative mortality morbidity has gone down, but nevertheless, the overall prognosis of the patient of glioma has not changed since 1970s. So we are almost 50 years. There has not been a substantial change in the overall survival of a glioblastoma multiformis patient. And this is the area where new treatments, new modalities of research is going on. And we should also know that when we offer different type of treatment to glioblastoma multiformis patients, we should remember this paper where it says that cancer, overall the cancer treatment in America are taking off 42.4% of the entire life asset is being used up on cancer treatment in most of the patients. So this paper from Oklahoma University is a very, very important paper for me, because we should not make them poor. Just because the technology is available doesn't mean that it is suitable for everybody. So we must have a proper informed consent about this. Now, some latest technology that is going on, ongoing trial therapies like glidel tablets that can be used in the tumor bed after you remove, and this is being used in many countries right now, and which has again added on another 3 months of survival. And another is electrical current that you pass in the brain, and then you wear it like this overnight for many days, about 3 weeks. And the idea is that the current will stop mitosis, because for mitosis there is a fibrin, you disrupt the mitotic pathway, the movement of the chromosome, and then you stop mitosis. That is the idea here. And this technique is very simple. Maybe you can use it for recurrent tumors or things like that. And it has added about 3 months, and there's no harm on this, and pretty cheap technique. And gene therapy or immunotherapy are some of the things. Like in gene therapy, what you do is, you get a virus vector, and then you inoculate it some kind of enzyme producing in the virus vector and inject that into the brain, and their survival rate has increased by again a few months in these cases. And immunotherapy is most of the time many of these patients are immunocompromised, or you activate their own immune system to fight against the tumor, because as you know, we are fighting with the tumor all the time. And we have tumor de novo tumor formation in our body all the time, and our immune system is fighting day in, day out, So just to boost that, and then, try to increase your own immunity, so some kind of vaccines. And this has also shown a very promising result, but not, such a big leap has been achieved. The study that we are doing in our institute is some plants that we use for cancer therapy. We are using HeLa cell, brain tumor cells, and other breast cancer cells, and these are the orchids that we use. And we have tested 11 plants, and there is a very, very promising result that we have seen in these cases. And so, these are different plants that you have used and in different concentration. The wild type and the tissue culture grown type, both have shown that these are very good cytotoxic values. So all of us, should also look at the things that is available around us and see what we can do to help our patients. These are the papers that our institute has published about the use of plants on brain tumor And now we are ready, at least 2 plants that we are ready to, launch as a add-on medicine for those where everything is exhausted, the patient have nothing to do now. Then we want to, just give them so that they will have few more months of palliative treatments. So in conclusion, the first thing that I think is that all of us, all the countries in the world should have a national cancer registry so that we exactly know how much of the brain tumor are being identified, because the picture that I showed in the early beginning is that after more CT, more MRI are being done, more and more of brain tumors are being detected. So if you keep a proper registry in the whole country, then probably the number of brain tumors will rise. And we should always operate on benign tumors. There was a time when benign tumors were not being operated, they were just being followed up, and you operate on glioblastoma where the result is not good. But then because of good skill, good armament of surgery, you can safely resect most of the benign tumors and cure them. So you must treat all benign tumors. Surgery for high-grade glioma depends on totally informed consent that you take with the family members, and if they think that they want to take, even if it's a high-grade glioma, they want to give the whatever is available to the patient, then you can go ahead and do the surgery. And we need to individualize brain tumor management so that it becomes more cost effective, and we need to learn to say no. This is now, it's okay. Like sometime I operate on a glioblastoma multiformis, they record and they come back to me and say, okay, we want another 6 months of life or 3 months of life, so please operate. Then most of the time I said, no, I don't want to operate anymore. It's not good. And so we need also to incorporate alternative forms of medical treatment in such cases. So this is the last slide that I have. Thank you very much for being with me. So, life is 10% what happens and 90% what you make out of it. So what happens is, what is the tumor that we have? If it's a glioblastoma multiformis, then, we are done with. But then there is 90% still space that we need to work on to get a good outcome in glioblastoma multiformis or a high-grade glioma. Thank you.
Okay.
Thank you very much, Professor. That was an amazing lecture.
Can I have some words?
Can you repeat, please?
Can I have some words?
Yes, of course.
Is there Dr. Basanta Banta available? Hello?
Yes, Herminia, how do you want to work it? Are you taking questions now, or what do you want to do, Herminia?
I think we should start with the Q&A session. I see a first question in the chat from...
Okay, we have someone asking a question on screen now. You want to answer that question? I guess you're asking if Dr. Rand's available, correct? Okay, Dr. Rand, are you here? Is Dr. Rand here, or did he leave? I don't know. Dr. Rand, are you there?
Dr. Pant.
I guess he may have fell off. Let me check to see if he's trying to get back in.
Yes, he's there. He's there.
Yeah, I'm here.
Oh, okay. I think someone has a question for you. Go ahead. There was a question.
How much time would it take for the hemiparesis to disappear in a young female patient? That's the question?
Yeah, well, that's one of the questions. You can start with that.
Yeah. So If it's a young patient and if it is a hemiparesis only, then most of the time, 3 months is the period when they get better, you know. But if it's a complete paralysis, then they may not get better even for a year or so. But if it's a partial hemiparesis, then most of the time they get better in 3 months.
Okay. Are there any more questions you see, Doc, in the chat?
There is one in the chat from Prajal, I think. Mobile phones uses radio waves which cannot cause any deterministic as well as stochastic effect like that of the ionizing radiation, so it might not be a risk factor, right?
Well, there has been a lot of research, a lot of discussion about this topic, and nobody has come into any conclusion till date. So I cannot say that mobile phone causes brain tumor. This is not for me, but then, you know, there is a high speculation that there is a possibility that use of a prolonged mobile telephone can cause a temporal lobe tumor, mainly on the right side. And there are many papers which support that idea. And there was some a prospective study done on this topic, but the prospective study didn't show any, you know, between the users, mobile phone users and mobile phone non-users, there was no statistical difference. So, you know, it's not concluded, but then they say that if the mobile phone is low powered mobile phone, then it emits more power, you know, and maybe the risk is more, but it's not very conclusive. But I think it's better to be careful and maybe not use, maybe use the earphone is a better way.
Okay. Okay, Herminia, do you see any other questions in the chat?
Yes.
Hello, sir.
Go ahead, go ahead.
Hello, sir. Namaste. Greetings from Birgan, sir.
Yes, hello.
Sir, I have been very much thankful to you because you operated my mom back in the month of June and she is getting all fine now.
Okay, thank you very much.
Good news.
Good
Sir,
news.
I have always been following you after that all. And the today's presentation was excellent, sir. I'm myself a medical student from Nepal Medical College studying in second year.
Good.
Very good. Good luck. Okay, do we have any more questions there, Herminia?
Thank you, sir, for such a wonderful.
Yes, there is
Thank you
one
very
more
much.
question. I read a recent article in Journal of Neuro-Oncology that stated significant superiority of lobectomy over GTR for non-eloquent gliomas. What are your views on this? And do we practice lobectomy in Nepal too?
Yes, we are doing lobectomy all the time. And so if it is a right-sided tumor, then we remove about 6 centimeters of the brain together with the amygdala and the hippocampus. And because most of the time the dominant hemisphere is on the left side. And if you are in doubt, then you can do a water test, as I told you in the lecture, and determine which side is the language area and which side is the memory. And if it's not the dominant side, then you can take out 6 centimeters of the brain. So more is better in glioblastoma. You know, you try to remove more, safe maximum removal. So lobectomy is done, and occipital lobectomy we do, frontal lobectomy we do. Of course, in glioblastoma we are doing this all the time. Yes.
Okay, there are any more questions? What is the role of cyberknife surgery in glioblastomas?
That's a very good question. Cyber knife, gamma knife, these are precise beam of radioactive substances that you put into the brain. It's actually, they call it knife, but then you don't use a knife. So you don't open the brain. So there's no knife here. But then it's a misnomer. But it's so precise. The resection, the targeting of the tumor is so precise that they call it cyber knife, gamma knife. Cyber knife is, you also take in consideration of movement of the brain, or movement of the chest, or movement of the abdomen. So if you consider the movement also, then you call it cyber knife. If you don't consider movement, then you call it gamma knife. So for GBM, as I have told you, that if you look at the MRI, enhanced MRI, then 2 centimeter, 4 centimeter away from the tumor, you still have tumorous tissue there. So even if you remove 4 centimeter away from the tumor, you still have tumor left. So they call glioblastoma multiformis a tumor of the whole brain. So precise, anatomically precise, localized gamma knife, cyber knife is not a way to treat radiologically, for glioblastoma multiformis. So once we do a surgery, most of the time it's a whole brain radiation that is done. So there is no, computer simulation, but it's a whole brain radiation that is better than the old technique is better in these cases, because the tumor is on the whole of the brain.
Yeah, I have a question,
you.
Doc, about
Yeah.
about high-grade glioblastoma multiform. Do you think the possibilities of lowering the rate of mortality with high-grade glioblastoma lies in studies in China and utilizing artificial intelligence in large amounts of people? Do you think the future is in research in China?
The research is always in China these days. Whatever is coming up is coming from China. So you talked about AI, and which is feeding the information to the surgeon how they should proceed with a special typical tumor. And I think there's a tremendous amount of future in that, because the computer will have all the previous information, previous surgeries that has been done, previous histologies, previous radiations and recovery rate. So it will give you, prognostic, how much the prognosis an individual patient can have. So I think artificial intelligence, especially on past events, the recording of a past event, which will give you an idea of what you should do today. This kind of artificial intelligence is going to be a very, very helpful in the future.
Okay, thank you.
Okay, I see 2 more questions. First, is there
Go
a
for it,
diet?
Herminia. Go crazy.
Is there a diet for the patient with in HGG?
No, I don't think there is any dietic restriction or dietic preference which will reduce the occurrence or, for glioblastoma as such. But then, we allopathic doctors are very, very poor in the information on diet. And we must accept that, because the homeopathic people, they know a lot of things about diet, but we know very little. So we say, don't eat too much fat, don't eat too much curry, or don't eat too much spicy things. That's all. We just talk the same thing all the time. But when it comes to or molecular level dietetic information, we are very poor. So my answer is may not be 100%, but then there is no known dietetic restriction on glioblastoma multiformis, although there are some dietetic restriction on other neurological disease, but not on high-grade glioma. And I see that there are other questions. So depending on
Yes.
what factor will the consultant predict the survival time of the patient, and how much will be the approximate accuracy? This is a best question for me. I have told many patients that you will not survive 6 months, and that patient will come after 1 year and shake my hand. So I have stopped predicting people's life, and it is not for me. I cannot predict. It is a science that we predict on thousands of peoples. It is not, we don't in practice individualized medicine. So we cannot say how this particular person is going to live, how much he's going to live, or when he's going to die. I have stopped saying this because I have been ashamed by people coming back to me and shaking my hand to the people that I've said you are going to die in 6 months. So I've stopped saying that. And sometimes, everything looks so nasty. We think that this glioblastoma multiformis is a very bad tumor, but we operate and it turned out to be something else, and the patient has survived for a long, long time. So miracles happen. So I don't think, we can say exactly how long a patient is going to survive. But as I've told you in my lecture, out of glioblastoma multiformis, if it's a wild type glioblastoma multiformis by IDH1, wild type, and then and other immuno expressions are bad, then these are the peoples which are not going to do good, and these are the people which will not survive. And most of the time when the people are elderly, 60s, 70s, these are the people who are not going to survive for a long time. But then I would not, I have stopped saying that you are going to survive 6 months, 9 months. I've stopped that saying that. I don't know.
Okay, and could you please elaborate on these cytotoxic plants found in Nepal? Has this been a recent event or has been used for before as well?
So this is, fortunately, my wife is, biotechnologist, and she's an expert of botany, and we have been working for a long, long time together. We did PhD together in Japan, and we have been working on different orchids and co-culture the orchids together with brain tumor. And we have found at least 4 orchids, wild orchids, which has got a very, very strong cytotoxic elements, but then it is not damaging the normal tissue. We have not done animal experiment. It's all in vitro experiments, and this has been published in different peer reviews papers. So, we want to promote these plants for people who have got nothing to be, most of the time we doctors say, okay, we have given you radiotherapy, we have operated on you, we have given you cytotoxic drug. Now there's nothing we can do. Then the patient becomes suddenly hopeless. So just to give them some kind of hope to hang on, we want to use these plants so that, and this is being very much commonly used in Switzerland as a tea, and in different other European countries, and we want to do the same. And we don't claim that it's going to cure brain tumors, but maybe it can add a few more months in their life, or reasonable life in their life. So that is our idea.
And if there is any role of cannabinoids in treatment of gliomas.
Well, you should tell me about that. Could be cannabis is being used in everything. Epilepsy is and neuromodulation a lot of times. So, who knows? I don't know. I'm not an expert on that. But Nepal is a place where you have, good cannabis. So somebody can do that study. And there is a question about robotic surgery has been a pioneer in resection of tumor in prostate cancer and has shown good prognosis. What about the role in neurosurgery? What level of precision? Well, um, the problem with the glioblastoma multiforme is the topic that I got. Out of grade 1, grade 2, grade 3, grade 4, glioblastoma multiformis is grade 4 and the worst type of brain tumors. So in here, the precision of surgery is not that important. And but then robotic surgery has got rules when you want to do a very, very fine surgeries. We have robotic surgery being used in many, bypass surgeries, anastomosis in the brain, things like that. But and stereotactically implanting different devices in the brain, especially in epilepsy surgery. But for glioblastoma, it's the disease of the whole brain, and then you don't need that millimeter sort of precision in. So I don't think there will be any role of robotic surgery in glioblastoma.
There are any more questions? I don't see any more questions. How do you deal and counsel patients who present with brain tumors with less survival time?
Yeah, this is a very important question. This is the most important question that we always ask ourselves, because we have technology which we use to extend their life for a few months, but we cannot cure them. And we must be honest with our patient and tell this fact to them. So in my slide, I have told you that my first option, if I think that this is a glioblastoma multiformis, and most of the time in our country, the patient pay from out of their pocket, and a lot of money they have to spend. And even in America, I showed you that 42% of their lifetime asset they use up in cancer management. So we must be honest and say that I think the patient have glioblastoma multiformis. If we operate on them, maybe we add few months in their life. The quality of life, how it becomes, is a question, because if the surgery doesn't go very well, they may have deficit after surgery. So we have to tell this very, very honestly. But most of the time, practically, what I see is patients say, okay, I know what you are telling, but my patient, I want to give my family member the best that is available. So please do surgery if there is a possibility. Even if it's very small, I want to try. I want to give that chance to my family member. So most of the time we are stuck with this. But there are some people who will say, okay, doctor, if you think that my family member is not going to make it, then let it go. So honesty of the practicing doctor is very, very important in a time like this.
Okay. Someone is asking if gliosarcoma is also a type of glioblastoma.
No, gliosarcoma is a different entity, and it's a worse tumor than glioblastoma, and it has got a sarcomatous entity in it, and it has got worse prognosis.
Okay, and Da Vinci robotic surgery is on trial in neurosurgery, although it has been used in neurosurgery.
Yeah, Da Vinci, similar type of surgery I just told you is being used mainly for very fine anastomosis, because your hand, how good your hand is, it's still shaking. So that is omitted in robotic, So if you do a very, very fine suturing, like 10-0-11-0 suturing of the brain, which is about 1/4 of a hair. It's so thin. So Da Vinci or similar type of robotics are used in fine suturing where you can omit tremors. And when you want to go precisely, like stereotactically, you want to implant 10 implants into the brain. If you do it stereotactically in a conventional way, then it will take a long, long time. Calculate each X, Y, Z, and then put the probes in each target. It takes a long time. But when you do it with robots, then they are doing it, just like this. So it's very, very fast. So epilepsy surgery, anastomosis, and very fine, precise surgery, it is pretty good. But it has got a lot of limitation, I would say, and it's nowhere near replacing a human being. I still want my head to be opened by a doctor, not by a robot.
Doctor, you mentioned something which I'd like to comment on, and it's actually part of the mission of neurosurgical TV, is to examine the interface of other sciences with neurosurgery, things like robotics, stem cell, artificial intelligence. And this particular platform of the Zoom, I think is valuable for work place for a neurosurgeon, because not necessarily this is education, but for a neurosurgeon to get together with engineers and other people in the panel, you can have a good working session, I think, with the new things that are happening, not just other neurosurgeons or other students, but with engineers, etc.
Absolutely correct. Absolutely. I have 3 engineers in my department, and the navigation system that I showed today is designed by our own engineer, and then it's made in India. And this is used from this video game. We copied a video game software and then used it. And our engineer is doing a lot of work on artificial intelligence, especially on eye tracking for paralyzed patients. And we do a lot of 3D printing, a lot of things. Today I didn't talk about it. Maybe next time I can talk a lot about these things.
That would be
we
great.
have a 3D we have a 3D printer, a very, very simple 3D printer, and we print our own, skulls in our own lab, and then which is very, very cheap. And with methyl methacrylate, we make our own bone cements and then implant it in our patients, and we don't have to ask the patient to pay a lot of money. So working with different faculties of biomedical engineers and robotic peoples, there's a lot of potentials of working together. And as I told you about artificial intelligence, which you asked, we don't remember all the surgeries that we have done, but if we pull down all the informations of the surgery that has been done by many, many peoples in one spot, and then give an answer from that, then you will have a fantastic answer. And that is where artificial intelligence can give you a fantastic, guidelines of how to proceed with one individual patients. So there's a lot we can do with computer engineering and biomedical engineering, artificial intelligence, and we should work together in the same departments, in the same operation theater. Most of the time, the the computer people are working in the computer and the neurosurgeons are working in the operation theater. They don't come together. You should have beer together. You know? You should cruise out together.
And this
then,
platform lets it happen.
Yeah.
This platform lets it happen.
Yeah, wonderful.
Yeah, and we look forward to hearing you. Really, that would be a great webcast for you to talk about how you're incorporating the new sciences into neurosurgery, essentially.
Yeah, I'll just give you one last example of how we innovated, re-innovation, I call it. So there is a particle called PBA, polyvinyl acetic acid, which we use to inject on brain tumors before going for surgery. And PBA particle was being sold by a company and which was not FDA approved at that time. So it was like a black market, you know. It was like buying a marijuana, you know. And then you have to buy every piece of it in $300 and then inject it. And I was surprised why PBA is so expensive. So I did some research on that and found that PBA, the molecular structure I studied, and found that it is nothing but spoons that you use to mop the floor, and which you can buy $1 a sheet. And that was when I was a resident in Japan, you know. And I bought this sheet and then scrape it on some kind of scraper, and then filtered with some kind of mesh, and then started injecting on human beings. That was in Japan. And then everybody started doing that. And one sheet lasted for 1 year, and it was $1, you know. So there is a lot of this kind of, I will call it not innovation, but re-innovation, you know. You kind of, you know, going around the innovation that has already been done in the West, and then, you know, re-innovate things so that you can provide it. So we have been doing a lot of similar things in our country, in my departments, and I can share that idea with you anytime, you know.
Well, that would be fantastic.
Yeah.
Anybody else have a comment? Sorry, Hermina, I'm taking your job.
Are some questions? Does a patient need to take levetiracetam till last day of survival after surgical resection of brain tumor, especially GBM?
Yes. So levetiracetam or any anti-epileptic drug, if you have a seizure and you are taking it, I recommend it to be taken for 2 years. The patient should be seizure-free. The patient should be aura-free. No aura, no seizure for 2 years, they can stop it. Any anti-epileptic drug, levetiracetam or any other drug. But if the patient had no seizure in presentation, but the doctor just gave it for a prophylaxis, then I would say they should only take it for 9 months and then they can stop it. So this is our protocol. And follow-up is first we do a 3 months follow-up, then we do a 6 months follow-up, and after that we do an annual follow-up, and then we do a 2 years follow-up. So depending on, you know, how the recurrence rate is coming, 3 months, 6 months, 1 year, and every 2 years. But this can depend, may differ from country to country, but this is how we are practicing here.
Okay. I have heard that COC protocol would be much beneficial in case of cancer, including GBM, which includes drugs like metformin, mebendazole, doxycycline, and atorvastatin. Is it true?
I have no idea about this. I cannot comment on this.
If I could get any idea regarding time interval for review MRI scan after completion of radiotherapy for a case of GBM?
Excuse me, I gotta mute somebody.
Can you repeat the question?
If I could get any idea regarding time interval for review MRI scan after completion of radiotherapy for a case of GBM.
I'm sorry. I'm sorry. I accidentally muted him. I'm sorry.
Can you repeat, please,
Yeah,
Professor?
yeah, let me try to get him. I don't think he realizes that was a faux pas. Can you unmute? I can't even find his name to unmute. Could you unmute? Unmute. Oh, for your punt. Okay, punt. Okay, just hold on. Okay, I got it.
Okay, unmute. Okay.
Okay, there we go. Sorry about that. My mistake.
So did you usually use 5-ALA in glioma surgery in case of total removal? So as I've told you, we are not using it that much. And unfortunately, again, coming back to my re-innovation, I told this in my lecture also, 5-ALA is very, very expensive. 5-ALA cost $1,500 for one injection. And most of the time, the patient cannot afford, number one. And number two, even if you use a 5-ALA, it will work on blood-brain barrier. So the pink that you see under the microscope that you remove, but still the brain, as I have said, 2 centimeter, 4 centimeter away from the margin of the tumor, they still have tumor there, you know. So 5-ALA may not be that helpful. But having said that, you know, it's a good tool that you can use. And this is a fertilizer. 5-ALA is nothing but a fertilizer. And they sell it in Alibaba in kgs, in tons. But when it comes to medical injections, then it is $1,500 for 1 gram. So I don't know why it becomes suddenly so expensive. So there were people who were using this 5-ALA from Alibaba as a tablet before surgery. And the one that we use is by injection.
Okay, see any other questions? Or comments?
I was on mute. Sorry.
Okay.
I thought the COC protocol is indicated in colorectal cancers.
I don't know if you can comment on that one, not being a GI guy.
I don't see any more questions.
Okay. Very good. Okay, Doc. We definitely have to stay in touch, and I'm looking forward to that. The way you're interacting with other sciences over there, and
yeah, it was wonderful talking with you all, young guys, and you know, maybe a future neuroscientist. I can see here a lot of future neuroscientists. And maybe I can talk with you in the future as well. Thank you very much.
Okay, thank you.
Thank you.
Okay,
Thank you.
okay,
thank you so much, Professor.
Thanks for arranging it, Prathana and Hermina. Thanks for the help.
Yeah, Subedi, thank you very much.
Bye-bye.
Thank you so much.
Thank you so
Okay,
much.
very good.